For any surgeon, sepsis is more than just a complication. It's a constant, high-stakes clinical puzzle. And, the entire way we think about it has been turned on its head in the last decade. So this explainer is all about that huge paradigm shift. We're moving away from a simple view of inflammation and toward a razor-sharp focus on organ failure, and what that really means for your decisions both in the ICU and in the operating room.
We're going to tackle this just like a real clinical case. First, we have to redefine the enemy. What is sepsis today? Second, we'll figure out how to quantify the damage. Third, we'll cover the immediate, time-critical counterattack. And finally, and this is the big one for us, we'll focus on the surgeon's most critical role, definitive intervention. Okay, let's dive right in. The absolute foundation of modern sepsis care is this huge change in the definition itself. And look, this isn't just semantics. It fundamentally changes who we treat and how we treat them.
So, in plain English, this is the core concept. The key takeaway here isn't the infection itself. No, it's the body's chaotic, out-of-control, self-destructive response to that infection. Sepsis is essentially friendly fire on a massive, systemic scale.
And here it is, the formal Sepsis 3 definition that makes it official. The two phrases you really have to lock onto are dysregulated host response and, most importantly, life-threatening organ dysfunction. That right there is the new center of gravity for our entire diagnostic approach. This slide really gets to the why behind this whole shift. For years, we relied on the SIRS criteria, the Systemic Inflammatory Response Syndrome. The problem? Well, SARS is just incredibly nonspecific. I mean, a patient with pancreatitis, major trauma, or even a straightforward post-op fever could easily meet the criteria. Sepsis 3 throws that out and forces us to focus on what actually matters: quantifiable organ dysfunction. That's the part that actually puts the patient's life at risk. And this change didn't just happen overnight. If you look at the timeline, the 1991 and 2001 definitions were both built on that shaky foundation of SIRS. The 2016 Sepsis 3 consensus was a very deliberate, conscious break from that past, moving all of us toward a definition that's way more clinically relevant and specific. Okay, so if organ dysfunction is the new gold standard, that leads to the next critical question. How do we actually measure it? How do we quantify it? Consistently and objectively, right there at the bedside.
This is really the core clinical challenge, isn't it? We need to turn this abstract idea of organ dysfunction into hard data that can drive our decisions right now.
The answer is the SOFA score, the Sequential Organ Failure Assessment. This is the tool that makes the Sepsis 3 definition practical. It gives us a standardized dashboard to check on 6 key organ systems, turning a vague concern into concrete numbers. For a surgeon, an early dip in platelets or a bump in creatinine can be that first subtle clue that there's an absolute catastrophe brewing in the abdomen.
So, here it is, the essential number you need to remember. 2. An acute jump in the total SOFA score of 2 or more points from their baseline when you suspect an infection, that is the clinical criterion for sepsis. It's not about the absolute number, it's about the change. And that change tells you the patient's mortality risk just shot up to over 10%. Now, the full SOFA score needs lab work, which can be slow and clunky if you're trying to screen a patient on the floor or in the ED. To deal with that, the Quick SOFA, or QSOFA, was created as a simpler tool for the bedside.
It's beautifully simple. Just 3 criteria you can check in about 10 seconds without a single lab test. The thinking was that if 2 of these 3 were positive, it was a huge red flag that the patient was at high risk for a bad outcome.
But, and this is a massive warning for every single one of us, QSOFA has turned out to be a poor screening tool. Its sensitivity is just too low. It misses too many patients, especially our surgical patients, where post-op changes can easily mask what's really going on. The Surviving Sepsis Campaign guidelines now explicitly recommend against using QSOFA by itself for screening. It's better to think of it as a marker for high mortality risk, not as a test for sepsis.
So, the moment we suspect sepsis, the clock starts. Everything shifts from diagnosis to immediate, time-critical action. And that brings us to the Hour 1 bundle.
These 5 steps aren't a checklist. They're a coordinated emergency response. Within that first 60 minutes, the goal is to get a lactate to see how bad the shock is, get cultures to find the bug, start antibiotics to fight the infection, and stabilize the patient's hemodynamics with fluids and, if needed, pressors. Now, the latest guidelines have added a really important bit of nuance around antibiotic timing. It all comes down to one question. Is the patient in shock? If they are, or if sepsis is definite, you've got 1 hour to get those antibiotics in. But if sepsis is just a possibility and the patient is stable, you actually have a 3-hour window to investigate. This is a huge deal because it helps us avoid just reflexively blasting everyone with broad-spectrum antibiotics.
And that brings us to septic shock. This isn't just bad sepsis. It's a very specific state of profound circulatory and metabolic collapse. To diagnose it, you need two things. First, the patient needs vasopressors to keep their MAP above 65, and second, their lactate is still above 2 even after you've given them fluids. When you hit this point, the mortality rate just skyrockets to over 40%.
Let's spend a second on lactate. It's so much more than just a marker for low oxygen. It's a critical indicator of widespread cellular stress and mitochondrial failure. Basically, the power plants inside the cells are shutting down. An elevated lactate, even in a patient with a normal blood pressure, can be a really ominous sign of hidden hypoperfusion, something every surgeon needs to be worried about.
All of this brings us to the climax, to the single most important topic for anyone in surgery, and that is source control.
Let me be perfectly clear about this. For a patient with surgical sepsis, everything we've talked about so far, the fluids, the pressors, the antibiotics, it's all just supportive care. We're just buying time. All of it will ultimately fail unless the source of that infection is physically dealt with.
Source control is the definitive surgical act. It's draining the pus from that intra-abdominal abscess. It's debriding necrotizing fasciitis. It's taking out that infected gallbladder or fixing that perforated colon. It is the physical interruption of the entire infectious process.
And this leads us to the final and maybe the most pressing question for us. That idea of waiting for a patient to be perfectly stable on pressors before going to the OR, it's a dangerous illusion. So often, the only path to true stability is the operation. The real question we have to ask ourselves isn't whether the patient is stable enough for surgery, but whether they have any chance of surviving without it.